All right, y'all. As everybody joins, thank you very much for joining us. So, as you know, our favorite surgeon of leisure, Dr. Nina Sue, is joining us tonight. She is going to talk about something that actually Gottschalk and I published a book on, and kind of a cool introduction, hopefully, for the fellows. You'll see how cool the history of Dupuytren's is, as well as I think a fair amount of interest in the book. So, without further ado, Nina, take it away. Thank you for joining us tonight.
Absolutely. So as mentioned, like the fellows for us, like you'll see it, it's on Gottschalk's like table area. So you can always read the book and stuff. It's actually very concise, very small, so it's very good. So I will, however, be covering it, and this is a very, very large topic, and we only have about an hour or less to talk about this. So there's obviously a lot of things I'm going to skip, and you'll get more information within the t textbook as well as other readings. So I'm just doing the highlights to maybe get us through. And it's really geared towards the trainees on this call. So you get a sense of, okay, what do you do when you see this? And then mainly, like, what should your decision making be? So some of the history, Wagner loves talking about this, but this is the only slide devoted to it. So the history is that it's most commonly associated with Dupuytren's in 1831. And it's been attributed to him in terms of the name, but actually it was described far before that, and as well as like the curse of the McCrimmons, as well as the hand of benediction. You'll read that all in the literature, and it's thought that that was all related to Dupuytren's. So introduction. So for those that don't know, so all the trainees should. So it's a fibroproliferative disease, affects the palmar aponeurosis, and worldwide prevalences is actually kind of it's a lot. It's 8%, and it's actually distributed throughout Africa, Asia, Europe, and the Americas. And there is definitely a more male prominence to it, and it's typically the age group you'll see is between 40 to 80 years of age. So etiology, historically, it was always thought that it was Nordic and Viking ancestry, but that's not the case, and you'll certainly see it in the population here in Atlanta. There have been multiple genome-wide association studies, and there are multi-genus interactions for Dupuytren's. However, for heritability, because certainly you will see some patients with family, like a very strong family history of it, it is autosomal dominant and has variable penetrance. So just because your grandparents, for instance, had it, doesn't mean yours will be worse necessarily, but it can be certainly. The risk factors in the literature are variable, so diabetes, liver disease, epilepsy, alcohol abuse, as well as like work-related vibration tools for greater than 50 years. The odds ratio is actually higher for these, and these are considered risk factors in the literature that's well documented. Terminology, and I think this is just a very brief thing, but just to talk about in the literature, Dupuytren's disease, Dupuytren's contraction, Dupuytren's diathesis is all used interchangeably, but they actually mean very different things. So the disease refers to the chronic condition because it's like once you have Dupuytren's, not all of a sudden, like even surgery isn't going to cure you, right? So you have this forever. Contracture refers to the functional impairment. As we all know, the fingers start contraction. And so Dupuytren's contracture refers to the fact that you start developing functional impairments. And the diathesis is indicative of a very aggressive course that you can have. And it's sometimes related to ethnicity, family history. It's for patients who have bilateral ectopic lesions and very early onset patients. You'll see some patients who are in their 60s and 70s all of a sudden start reporting it, but those with very early onset typically have a more aggressive course. And certainly you have to look at uh, palmar fib if they have nodules in like the soles of their feet or on their penis, that particularly may indicate a more aggressive course for your Dupuytren's contractures. So as a reminder, Dupuytren's is actually normal structures that become abnormal. So this is just a very um, like simplistic form of looking at. So the normal structure, the pretendinous band, that is normal. But then when it becomes pathological in Dupuytren's, it becomes the pretendinous cord. Same for the natatory ligament, which becomes the natatory cord, and that limits the digital abduction you often see with these patients. The central fibrofatty tissue becomes the central cord, which leads to that PIP deformity. The spiral band becomes a spiral cord, and that's the one classically on the OITE that talks about what is displaces the neurovascular bundles superficially within danger of getting cut during your surgery. And the lateral digital sheath becomes a lateral cord, which leads to PIP and DIP contractures. So clinical presentations, it's really painless nodules and cords, and I think most of us have already kind of seen it present. But the long and ring fingers are most commonly affected, but the small finger can also be obviously affected. And really, the key here is that these are painless cords that people have. Sometimes people complain of like a mass effect, so when they're gripping things, that the nodule is very large and it causes some discomfort because sometimes it can be quite large, particularly if they're contracted down. So maybe they'll talk about discomfort related to that, but the nodule itself should not be causing pain. So physical examination, I think the classic one is the tabletop test. You ask them to put their hand flat and they can't. It kind of lifts up like this picture. You also have Garrett's nodules on the back of the dorsum of the hands or ectopic lesions elsewhere. You want to obviously, during your physical examination, do a very good physical examination. So you're looking at both ulnar as well as radial digital nerve distributions to make sure that that is in fact intact. And then always look for differential diagnosis. Sometimes fingers can just be contracted down, and that may be something completely different, right? So you got to think, okay, is this a trigger finger that now has just become a lock trigger? Because you can certainly get that. Is this osteoarthritis? Maybe they're just stiff, and that's why the PIP is flexed down. So you, and then you can have missed dislocations too. Probably Nikki sees this all the time, but like, but missed this. Okay, so these are part of the differential diagnosis. Just because you see a flexion contracture, you have to always take a step back and it's like, okay, I think it's this. But obviously, if you have the classic cords and nodules like I showed on the last picture, obviously likely Dupuytren's. But there are some patients where the cords and nodules are very minor, and so you have to think of your differential diagnosis. So I just put that in. Not every flexion contracture is Dupuytren's, and it can also just be from, let's say, a distal radius fracture. They got their hand stiff. They weren't working on range of motion. They get stiff. That's not Dupuytren's. That's stiffness. So indications for intervention is obviously extremely controversial. What I like to think about is like once your MCP contracture is greater than 30 degrees and your PIP contracture is greater than 15 degrees, that's probably when you're starting to think of an intervention. And that's like some type of intervention, sort of. And the literature would support that. However, there is a lot of variability within surgeons in terms of like what they consider as their like threshold to start offering some type of intervention. So I try to be very holistic, and when I think about my patients with Dupuytren, so I kind of look at three major factors. I look at the patient factors, so the age and the medical comorbidities, because that will affect sometimes if this is a heavy smoker or has very bad uncontrolled diabetes, if you do something where you're expecting healing by secondary tension, that may not happen, right? Or you may increase their risk for certain things. And then you also want disease-related factors. So palpable cords are always much nicer, I find, much easier. You'll notice there's some Dupuytren's where it's nice and a very defined cord. So that I think personally increases your option to do things. Um, and then, but if it's like there's also you'll see Dupuytren's where it's almost like the nodules are very spread out, and you're like, I don't know, for instance, if needle aponeurotomy work because it's like this nodule is so large. Next is the contracture severity and also where that contracture is. So the MCP historically, as we all know, do better than PIP contractures, and certainly when you do needle aponeurotomy, you're a little bit, at least for me, um, I'm a little bit less wary about like fixing the MCP contracture, but once you're doing needle aponeurotomy past over your phalanges, I start to worry a little bit. You will see some wonderful results for people who actually will do multiple needle aponeurotomies all the way up to the DIP, and it's incredible. I personally have not done any needle aponeurotomy for like the DIP joint just because I'm too worried about getting a nerve, and to me that's not worth it. But you most definitely can. And then also cutaneous involvement. Next is intervention related factors. So one like institutional, like in terms of cost or cost to the patient, like for instance, Xiaflex, like if you really don't have insurance, it's really cost prohibitive to have Xiaflex. And unless, or you could be like me and just be big budget, you just want to spend a lot of money. So then you do whatever you want. But irrespective, like cost is a consideration sometimes because maybe the patient can't do it. Or more importantly, also cost related to the fact that if you do surgery, that patient probably has to take some time off work and be like a one-handed bandit, right? So maybe they can't do it. So it's when I talk about cost, I talk about like the financial cost as well as the economic cost to the patient. surgeon experience with respect to like how comfortable are they doing it, right? So if you've never done XIAFLEX, you may not do XIAFLEX, but if you do it, then that will be part of your like armamentarium to deal with this. And then post-op recovery, I think, is related to the patient. They have to really understand, and I really do couch my patients a lot. Like the post-op recovery is very variable between the different interventions. So they have to understand because if they don't comply, then I think the results of your surgery or intervention decreases. So I just put this on because mainly to show that they're like in all orthopedics, there is staging of everything that every disease that we have in hand. So these are three of the most common staging for Dupuytren's, and it's mainly the higher the stage, the worse your contracture. Okay, so I'm not going to go over this because I don't think it's really relevant for this particular talk. So intervention options, we have a couple, right? So as we like to do, we like to split it between non-operative and operative. And non-operative is like multitude. So splinting in the literature has not been shown to really prevent the progression of Dupuytren's, so I don't use it. There's also literature talking about pharmacological adjuncts such as steroid injections or fat injections. And again, I have that the literature wouldn't necessarily say that's going to prevent your recurrence. Radiation is extremely common, and you will notice in the book there's a wonderful author who wrote on that particular chapter, like on radiation. It's most commonly performed in Europe, most noticeably, most of the literature comes out of Germany. And so usually it's actually 30 GYs are like considered the dose amount, and usually that dose is separated over five intervals. There are some currently, an American study looking at doing surgery and radiation, seeing if it's makes a difference. But globally, it's very variable. So I think the German the Radiation Society will advocate for doing radiation for early Dupuytren's versus like the UK board doesn't recommend it, and it's unknown in America. And so I would say it's very, very rare. I've had one patient that requested it because they obviously did their research and stuff. So there is somebody on the Emory side that you can go send to talk about it. So they want to talk about it, but I wouldn't say that that's super common, and the literature is not super strong on it. But if you're going to do radiation, it has to be very early Dupuytren's. It can't be the very, very well established because radiation works with damaging the DNA in the proliferative phase, which is early for Dupuytren's. So that's just a little bit about radiation. So it's an option. It's not really the most common. I think the next two, collagenase and needle epinurotomy, are the most common and the ones you should absolutely know, being a hand surgeon here in the US. Collagenase has been pulled off of all the markets except for the US, however. But when it was there. Uh, so collagenase has been pulled off on all the markets, but it actually, when I was in Canada, like people who like collagenase love collagenase. They really do love it because it is something where they can avoid surgery. So I still do it, of course, for patients, and then next is needle epinurotomy. Needle epinurotomy typically is one of my favorites comparatively to collagenase, but both work very, very well in my opinion. Operative, so there, yeah, go ahead, Nikki.
So I'm sorry, I missed it. I didn't realize they pulled collagenase off the market everywhere. Is that just because the high rate of recurrence?
No, it's actually cost because it's
Oh,
very expensive, right? So it used to be in Canada, it used to be everywhere in Europe and things like that. And it's not because it like doesn't work. It's just there's a cost factor to it.
huh.
Hmm. So
Okay.
it got pulled actually from Canada just actually after I moved to the US. So it's I think it's been pulled out of most markets, but not because of safety concerns or anything like that. So operative, there's kind of three options for operative when you say you're going to excise the Dupuytren's. So there's kind of like limited fasciectomy, which is by and away the most common and what you've probably seen throughout your training is where you excise the diseased fascia. Rat, radical fasciectomy should be when you excise the diseased as well as the normal fascia. And dermatofasciectomy is sometimes you'll see Dupuytren's where it's really, really adherent, right? There's really no layer between the diseased fascia as well as the overlying skin. So people will just like cut that diseased skin out. And then finally, you can't forget about continuous extension torque, which is like the digit widget, for instance. When I was in Canada, I didn't use the digit widget very much because of cost factors. But the times that I have used it, I do think it's good. And there are certain indications where I feel like you most definitely need to talk to your patient about it. Gottschalk loves this, loves the digit widget. So if anyone like wants to see many, you can probably go to his clinic, go to his OR. But I will use it certainly for certain things. So I think operative technical pearls and considerations that I think about with everything is it's like you really want to set the realistic patient expectations. The one thing I really think like most patients with Dupuytren's are extremely well educated about their condition, right? So they've read about it, they know the options, they've gone to a couple of people, so they know, but I still set realistic expectations because the number one problem with Dupuytren's is of course like recurrence, right? This is something that we have to live with and manage, but not necessarily, it's not like something I can just get rid of, right? So trigger finger, you expect to get rid of that. You will not get rid of Dupuytren's. So what I say in general is that the results for MCP contractures, it's almost always correctable. That's great if you just have a Dupuytren's affecting that. PIP contracture, that's when you are like less than 45, maybe it's okay. It gets really difficult to get a good correction that will last for over 60 degrees. And the literature would say that more severe PIP contractures are harder to control. So that's actually kind of like my threshold around 45 at the PIP to consider talking to the patients about doing a digit widget. Although it's ironically been a harder sell in the US and Canada, they typically would just do whatever I wanted. But here they have opinions. So so sometimes they don't want to deal with the external like apparatus, right? Because it is very large and I will show my patients. And usually some patients are very good about it. And patients who understand Dupuytren's, they just want the maximal correction. So then they are very, very happy to do the digit widget. And then DIP correction is almost always difficult, but it's actually not that common and it's not that functionally impaired. It's really the PIP contractures and MCP contractures that people have a lot of problems with. So I think principles always is to pick an appropriate skin incision and you want to avoid the avascular flaps. So and yet at the same time, you have to balance. You don't want to leave that pathological tissue behind. So there's multiple skin incisions that you can do. You can do Brunner incisions, which is on the long finger. You can do hemi-Brunner incisions. Like Scott Wolf, when I was a fellow, he loved doing these hemi-Brunner incisions. And then longitudinal, which you then do Z-plasties or Z-plasties. You could also do mid-lateral and then transverse. So the transverse is like considered like that McCash technique where they just go across. Like I haven't done it, but I have seen it. But whatever you do, you got to think about like, okay, can I close this? What am I going to do after I remove all this tissue and help with the contracture? Because of course, if you're bent down and you release, now you have more area to cover. So skin coverage, there's many different ways. You can do like little Z-plasties just to help because the last thing you want to do is then you do the surgery and then you end up because of the skin, then having your finger tethered down. You can do antecubital full thickness skin grafts as well, potentially. And this is the transverse one. I didn't do this one on the right side, but it's the McCash where they just heal by secondary tension. I will do for like very small Dupuytren's, particularly in fingers, if there's certain small areas, healing by secondary tension, as we know, does very well. So I do like to do that. So of course, you always want to be aware of the neurovascular bundles. I always start proximally and then I always work distally to excise the pathological tissue. So if you look here, this is on the markings on the nerve. The marking is on the nerve, so it kind of goes here. It went underneath this cord and then popped up over here again. This is actually the artery. So it like Dupuytren's, the only predictable thing is that it tends to be very unpredictable where the location is. So you just have to be mindful. So you want to go into you want to start normal tissue, work towards your pathological tissue. And of course, bipolar cautery is absolutely necessary for this procedure. Because I remember when I was a resident, my senior attending, he would just like buzz nothing. Then he would tell me to like put like pressure on the wound and then he would deflate the tourniquet and walk out the door. And then I would be buzzing for half an hour because all these little bleeders and things like that. And then mainly you need to know your anatomy, right? So this is a little bit of the whole, like, you have to know your anatomy, and we're not going to go through this, like, because this is not an OIT session. However, like, you have your central cord, and it's really responsible for the joint contractures most often. And those are the common ones that you see. And those are the nice ones that I like to see for the knee aponeurotomy. You have the spiral cord. So that's the one that's very concerning. And that's the one where it goes PIP contractures, and it draws the neurovascular bundle proximally, centrally, and then superficially. So normally we have a thing when we do our Bruners for the fingers, like if you stay midline, you're pretty good. The neurovascular bundle's on the side, so you're good in the center. You can't trust that with Dupuytren's. Lateral cord comes from the lateral digital sheath, and the natatory cord is often responsible for the web space contractures that you sometimes get. You want to make sure you get that for the patient because it's like sometimes the fingers can get quite crunched in as well as flexed down. The retrovascular cord is actually comprised from the dorsal digital fascia, and it's responsible for DIP extension contracture that you sometimes get. But again, I don't worry so much about it. The ADM, however, is something, the cord for the ADM, for the baby, the small finger, that is something that you should be mindful of. And when you're dissecting for the small finger, you should look for it and excise it. But that also draws your neurovascular bundle to the midline. So principles is that one thing is like you can't resect everything. You need to leave back the normal tissues, which means you need to know which normal tissues to leave. Okay. So the pulleys, obviously, you want to leave it because the worst thing in the world is that you're like happy you dissect out everything and you take out all the pulleys and now they have a flexion contracture from bowstringing, not because of the Dupuytren's anymore. You also don't want to damage the tendon. It's usually the tendon is well defined, but if you're seeing the tendon, that means you probably have taken out the pulleys. And sometimes you may intentionally do that, but you at least have to know that you've done that. And the normal fascia neurovascular bundles, of course, you need to make sure you protect. So significant contractures, as I mentioned. So when you're looking at significant contractures, particular of PIP, because we know that those do very poorly, you have to think preoperatively like that maybe like this patient is somebody that I would talk to about getting a digit widget before they would undergo surgery for a limited fasciectomy to remove the diseased tissue. Because the results of doing this, so there's a couple of problems, right? Your PIP is essentially in this patient about 90. You can probably remove everything. You can probably get this finger straight. Sometimes if you have a residual 30-degree contracture, then sometimes you have to release the actual joint. But what you also have to worry about is that these vessels have been crunched down for quite a long and contracted for often a long time, and you're going to all of a sudden like bring it out straight. Sometimes it spasms. So I always make sure I have warm saline. You can also have lidocaine, papaverine, everything to try to help it so that if for some reason, and of course, if you're doing the procedure, I always deflate the tourniquet at the end of the procedure to make sure that the finger is actually being perfused. And sometimes it's not. And so what you do is you just have to flex it, warm water, keep it super, super warm, and then test again, right? And then sometimes you can't bring it completely out straight. So sometimes I will purposely kind of make it better than it was, but like maybe leave a 20-degree contracture at the PIP. And then in clinic, I will use it to have a therapist start extending that out. But you don't want a dead finger. And you should be thinking about doing a digit widget or some type of extension torque treatment. So complications are obviously numerous. Neurovascular injury is probably the most common, not because necessarily you cut it, hopefully, but you can also just from traction, like you've just taken something that was bent down and opened it completely. Wound closure issues is obviously a problem. There's also vascularity concerns, which is kind of related to the neurovascular injury. But the number one complication for patients, maybe not for you, but for patients is the recurrence, right? So this is something you need to actually talk to the patients about and warn them about. So what does the literature say about Dupuytren's contracture? So there was a 2015 Cochrane review, looked at a couple of articles. There was just under 1,000 hands with 1,000 participants. So they found DASH scores were lower after needle aponeurotomy compared to fasciectomy. Fasciectomy improved contractures more effectively in severe disease, and the 5-year satisfaction was higher in the fasciectomy group compared to the fasciotomy, because most often satisfaction is related to lack of recurrence. And then recurrence was greater after fasciotomy, which I think most of us understand and most of us know from the literature. And then skin grafting did not improve outcomes, and splinting was not found to be effective. So I splint postoperatively because I tend to be extremely conservative and I'm very scared, but the literature would not indicate that that's required. And I do tell my patients if they don't want to do it, they don't have to do it, but I typically will do it. And then there's insufficient evidence to show that needle fasciotomy is better than fasciectomy, or the interposition skin grafting versus Z-plasty closure is any different. So I think it's like my conclusion from that is kind of like fasciectomy is a viable treatment. You have to understand the anatomy. And then limited fasciectomy, you should probably it's very common, and I think that's what most of us would do if you're considering surgery. But sometimes it's not unreasonable to also talk about salvage procedure, particularly in the setting where the patient has had multiple surgeries. Or I have had in the rare instance where I've actually done an amputation for patients simply because it's like these were manual labors. Every moment that they weren't working, they were losing money, and there were farmers back because when I was in Canada, we had a lot of farmers and stuff. So I've rarely done it where he had a very strong family history, and he saw like his parents constantly doing these surgeries, and he didn't want that for himself. So he actually had a ray amputation. But again, that's probably not the first surgery at the shoot, but it's something to think about, that there are salvage options, and sometimes in the right patient, properly indicated, that may be an appropriate treatment. So needle aponeurotomy, I like this quite a bit. It was first published in 93. It usually leads to faster recovery. Recurrence rate is very variable in literature, and reintervention rate is 61% at 5 years in the literature. Again, there's a bit of a range there, but I've just put that up there. And I think a lot of patients, they don't mind the reintervention rate, at least from my perspective, because the people who are doing this often don't want to undergo a full surgery. So they're willing to let something heal through secondary tension, a small area, versus go through the whole surgery. Technical pearls, I use a 18 gauge, but some people will use a 22 and 25 gauge. I like the 28 just because it gives me more control. I just put lidocaine without epi in the skin, and I'll place a towel on just the back of the dorsal metacarpals, and so that the phalanges are left free, so I can fully extend when I'm doing my needle aponeurotomy. And then I flex my MCP when I'm doing PIP extension, and then vice versa. Complications, of course, are skin tears, nerve injury, because even as I said, you don't know where the neurovascular bundles are necessarily. So you might have a nerve injury. You want to warn the patient. So I usually tell my patient, you need to tell me if you feel like an electric like shock up the finger or something. And hopefully you haven't accidentally numbed the whole finger and you've just numbed the skin. Obviously, local pain. Flexor tendon injury, sometimes if like I personally think it's better to do a couple of spots where you're doing the needle aponeurotomy versus one spot like really deep, because you might get the flexor tendon. Obviously, infection. I've never actually had an infection during needle aponeurotomy, and I don't use antibiotics routinely, but obviously you have an open wound, so that's always a concern. And then you want to be mindful of ADM as well as natatory cores, where they may limit your ability to actually see full release of the hand. So collagenase is obviously a very big one, and a lot of people are well versed in this. I think if you don't have insurance, this sometimes becomes cost prohibitive. I have had some patients just pay out of pocket, even in Canada, for this, just because they wanted it. Because for a while, collagenase was not covered under our health plan, but some people still did it. So Cord 1, Cord 2 studies, one in the US, one in Australia. These were the studies that helped kind of establish collagenase as a very viable option, because they did very well, because their primary endpoint was reduction in contracture to less than 5 degrees within 30 days, which is very good. And these were randomized control trials, which is, what we consider the highest form of evidence, right? So technical pearls, when I first started doing them, it was very rigid in terms of what you could do. You could only do one injection, one digit. Now they talk about doing multiple injections, multiple cords. So I think the indications have expanded and of its use. And I think it's better for the patients too, because you can actually use quite a bit there's a lot of medication in that little vial. And originally you'd be throwing out most of it. So most surgeons now will use the whole vial to inject in different spots. And then I believe the original said 4 days. So I usually wait about 7 days, and I've just found less problem with skin tears or skin issues and things like that. But of course, again, same type. The one that is probably most uh, unique to collagenase is you really have to warn the patient about the fact about hematoma, edema, and upper arm lymphedema. Because if they don't know, sometimes the hands can look very impressively like somebody took a mallet to their hand and it looks very swollen. And then some people, when they get the lymphadenopathy in the upper arm, it's like very prominent. So if you don't warn them, they get a little bit disconcerted, understandably. Next is where they kind of looked at this is the cordless trial. I must say they have just the best names ever for their trials. But the cordless trial looked at long-term evaluation, and there's still a relatively high recurrence rate after collagenase, but the patients avoided surgery. So if you look at other systematic reviews for collagenase, it's about 10-31% recurrence rate. Of course, it depends because PIPs always perform worse than MCPs. The local complication rate was very high with collagenase, but major complications is very low. So what do you do now? So I kind of think of success and failure. It's very heterogeneous in the literature, and you want the ideal treatment, right? So the ideal outcome is that you have less than 5-degree extension deficit. There's no recurrence, no complication, short recovery. Like that is your ideal. But then you also want to avoid the complications. So swelling, edema, bruising, hematoma, nerve injury, recurrence, and mainly persistent contractures. So people, you'll do a knee operotomy and like you fix like I had a patient who I did the knee op. I explained, well, I thought I explained about how like, the PIP is often hard to correct. So I completely corrected their MCP and they're like, oh, but I still have the PIP, right? So the persistent contracture is a problem for patients. You need to counsel them about that. So this is actually a slide from Spencer Chambers, our prior fellow, because he actually broke it down quite nicely about like looking at, okay, between collagenase, needle epidural, and limited fasciectomy, which is the most common like 3 treatment modalities that most people will come to you asking about, and most that you will probably put in your armamentarium, things that you want to like think about. So it's like 5 factors kind of. So initial improvement, the recurrence rate, the recovery time, complications, and patient satisfaction. So we're gonna like do a little whirlwind of these 3 treatment options with those 5 modalities. And the literature, there's tons of literature on this. Like Dupuytrens is extremely well published, and there's a lot of things on it. Like I'd probably get in trouble if I didn't mention this one from Eric Wagner, looking at the outcomes and direct costs. It's one of the few studies that actually looked at comparing the 3 interventions directly. So it's actually quite a lot of interventions. It's 848 interventions. And Marco Rizzo, I consider like an extremely honest surgeon with respect to his outcomes. So I do trust this. So they found small fingers most commonly affected. The 2-year rate of reintervention is very high for collagenase, lowest with limited fasciectomy, and then needle aponeurotomy kind of sits in the middle there, sort of. So younger age PIP severity was predictive of reintervention. Limited fasciectomy, as we all understand, is that it's going to have the highest initial cost, but the lowest intervention. And then collagenase had the highest reintervention at 2 years and the highest cumulative cost. So if we look at this, we look back to our 5 factors. So initial improvement, I would say is probably pretty similar. Recurrence rate, limited fasciectomy probably does the best, and needle aponeurotomy and collagenase is pretty similar in the literature. So let's look at recovery time now. So recovery time, limited fasciectomy, I usually say very reliably 6 weeks, right? So because oftentimes, sometimes the skin doesn't heal completely. So and then in terms of getting back to range of motion. So I would say 6 weeks. It's probably 2 to 6 weeks, depending on if you had to do skin graft or Z-plasties or however you used, or secondary intention to heal your wound. Needle aponeurotomy, it says 1 to 2 days, but it can be longer depending on how big your skin tear is. And collagenase, it does require like a 5 to 7 day second visit. And then if there's a skin tear after that second visit, then of course it might extend it. So if you look back, probably limited fasciectomy may still have the longest because obviously the incisions are larger. And then collagenase may be in the middle, and needle aponeurotomy has the shortest recovery time. Complications, as I mentioned from previously, there's really no difference in the literature in terms of serious events. So like digital nerve injury, tendon injury, digit loss. There's obviously, in the cord, I forget if it's cord 1 or cord 2, where they got flexor tendon injuries and things from their collagenase. So, but irrespective, like by and large, the complications there's really no difference in major complications, I think, between these 3 options. And then patient satisfactions. I think patients, I think patients with Dupuytren's contracture are some of the most pleasant to deal with because they have research well. There's a lot of resources online and stuff, so they're very well educated. So I think patient satisfaction is probably equivalent to all three. Like whatever I've done, most patients have been satisfied because vast majority of time they have chosen, right? So I think if they understand the trade-offs between every like the different options, as well as you explain the alternatives so they don't feel like they've missed out on something, they're generally extremely happy. So this is kind of a summary of events where you look at. So the best is kind of where you want to be. So again, like when I first started my practice, I did a lot of needle aponeurotomy because I could do that in clinic and in Canada, like OR resources were extremely tight. So I really like it. I still do like needle aponeurotomy a lot. When collagenase came through, that was fun. But then some people are really bothered by the lymph nodes. So that was good, and then that was like sometimes cost prohibitive. So although I did it and I got good results, like I usually my go-to if I was not going to do surgery was needle aponeurotomy. But I have actually progressively over time moved more towards doing limited fasciectomy as my first line, particularly in more severe conditions, mainly because it's like I want to decrease the recurrence for these patients and not continually do it. There's only a few patients that don't mind coming in to see me relatively frequently for needle aponeurotomies, almost like a little tune-up or something. So if you look at cost, so this is a US study. So they actually found that limited fasciectomy needle aponeurotomy can be cost effective, pending the contracture severity and number of digits involved. But like they didn't find necessarily that collagenase was cost effective. And then PIP recurrence limits the cost effectiveness of any interventions because PIP contractures tend to kind of recur. In the UK, they found limited fasciectomy is the most cost effective to treat moderate to severe contracture. Needle aponeurotomy is cheapest, but limited fasciectomy generated more quality of life units. And I think that's quality of life years. And I think it's because it's like of that recurrence that they're able to see it get straight and use it right away. And then the increased cost of collagenase compared to needle aponeurotomy was a less gain compared to in the qualities compared to limited fasciectomy versus needle aponeurotomy. So there's some trend away from collagenase as being an extremely expensive treatment option, which obviously is going to be reiterated in Canada, which tends to be extremely cost effective when they want to do something. So, but they didn't find limited fasciectomy as cost effective for single digit, but obviously if you have multiple, it may be. And then needle aponeurotomy was found to be cost effective in treating single digits. So this is kind of like the cost summary, I would say, taken from different places. So limited fasciectomy is probably the most cost effective if you have severe disease or multi-digit disease. And I agree with that. And that's kind of like how I've geared my practice. Needle aponeurotomy is probably cost effective for a single digit and then MCP because MCPs do extremely well. And there's really no great treatment for PIP because the recurrence rates are very high. And so really anything you do, you're always going to fail eventually for the PIP potentially. And then collagenase, uh, the advantages of collagenase over something like needle aponeurotomy, it's a little bit unclear because collagenase is so much more expensive just than compared to an 18 gauge needle. But I would say like worse disease justifies more expensive and invasive procedure, which is surgery. So, kind of my final thoughts here is that discussions, of course, with your patients is imperative. And I do tend to advocate for less invasive measures, particularly if it's a nice cord. If it's a nice cord where the whole hand and it's right in the center and things like I usually do like to do needle aponeurotomy or Xiaflex. Severe contracture, though, sometimes it's better to like not do like these little procedures and just go directly to surgery. And oftentimes I feel like it's just better for you as well as the patient. And that is all. Thank you, everybody. Oh dear. Hang on. Let me get out of here. Okay. Any questions? So Tim and Cam, did your attendings kind of use the collagenase needle aponeurotomy? What was their
That was
preference?
that was a great talk, Dr. Sue. Thank you. My question actually stems from that. We almost exclusively used collagenase for non-operative management, both at our VA and at our regular hospital or university hospital.
Yeah.
So what are some pearls for the needle aponeurotomy to avoid damaging the neurovascular bundle? And I think you mentioned you don't typically do it for digit chords. You do it typically in the palm, but
Yeah,
any
no, I will do it, but it kind of depends on the actual cord. So I usually like the cord to be kind of separated from the tissues below, and that's usually when I will do it. The collagenase I think also works extremely well for that, but needle aponeurotomy, it's obviously more dangerous as you go more up into the digit. Wags, I don't know if you have a preference if you prefer needle app versus collagenase.
Yeah, my bias is towards neonat because I've done a couple surgeries after collagenase, and just really hard to do those surgeries. Whereas doing surgery after neonat is not really hard to do. So if you have somebody that fails, and both of them fail at about 20-30% rate at 5 years, I think, for me, I'd rather revise that. But I mean, that being said, I offer both. I've actually gotten my PAs to be trained to do collagenase, and they've started doing it. So they'll inject, and then we'll sort of manipulate together. And so I don't know. If the people want collagenase, I'll do it. But I personally feel better doing needle app.
Yeah. How about you, Paul or and Bill? What do you
You
guys?
know, I switched. I used to do a lot more collagenase. And like at UCLA, Prosper Ben had did all collagenase. Like
Oscar has
every
great results with needle app. Oh wow.
he did. I know. So he did needle app, I think, like a ton of needle app, and then he switched 100% and did all collagenase. So when I was there, all I saw was Xiaflex, and so I came out doing all Xiaflex. And then I switched because it was like getting challenging to get the Xiaflex sometimes. Like it would take a long time to get it approved or take a long time for them to ship it, and then I had to bring them back for multiple clinic visits. And at the VA, same thing. Like we used to have easy access to it, and for some reason they kind of shut it off. And so I just switched to needle app, and now I love it. And I still offer patients both, but usually whenever they're like, okay, between these two, less invasive, like, what do you prefer? Usually I'll kind of tell them, I think they both have reasonable outcomes, but I've kind of gone to needle app. And I
Yeah.
think patients have been happy with it really overall. I have gone into the fingers. I haven't had a digital nerve injury yet, but I mean, it's definitely possible, and you want to be careful of it, and you want to make sure when you're anesthetizing them, you're just trying to anesthetize the dermis, and you don't want to do a digital nerve block. And you want to, I usually will start distal with my lidocaine, just, inject my distal port and then do my needle app and then go a little bit more proximal and kind of work from distal to proximal. Because once their digital nerve is numbed up, and they won't give you that Tinel's sensation. And that's what you're looking for to make sure you're not too close to the nerve, I think. But yeah, I've liked needle app. And then I still, of course, do surgery as well. And Eric, to your point, I just did somebody last week that had collagenase twice. And then I did surgery on him, and it was tough. I mean, it was really hard. So I agree.
It just like smears out or something. It usually like it's not nice and clean like a dupe because it's
Oh yeah.
if you have a non like a virgin Dupuytren's that you just go in, even though it's hard wherever the neurovascular bundles is, the actual Dupuytren's cords are very nicely delineated for you, and
Mhm.
the tissues do fall away. So I would agree with you. But yeah, I like needle app. Like some people like because like Prosper goes right up right at he's done like I've seen his like thing where he does like DIP. I'm like, oh, that seems. I guess if you cut the nerve there, it will just heal, so you wouldn't even fix it. But like, I
Yeah.
just get really nervous getting all the way up here. I've done it over the proximal, the middle phalanx. Like, you usually that's not a
Yeah.
problem because that's not where it is. It's usually
Yeah.
over the
I've
proximal.
never gotten to the middle phalanx. And I'll say he probably never saw them back to know if they had any nerve injury or not. So,
Fair, fair. But yeah, no, I like needle episiotomy also because it's the instantaneous result of it. So that day
Mhm.
they first see you and then you do it, then you know whether it's going to work or not, right?
Yeah. And when Gottschalk told me he was doing them in the clinic and he got them all kind of approved and no, insurance and payers like paid for it, I started doing it in the clinic. And it's nice because the patient's sitting right there. You kind of get them that immediate correction and they see it, you see it. Xiaflex is the same way too, where they get that correction whenever you manipulate and there's usually like a positive feedback with that from the patient. But yeah, I like it.
So Tim, probably what I would do for you is like when you do a needle, like a limited fasciectomy in a patient. So prior to that, you should try a needle lap on the patient potentially, right? To give you a sense, because I like to put tension on it to make sure that you're really accentuating it as much as possible and lifting it off the tissues below. But yeah, needle aponeurotomy, I like the instantaneousness of it. And so that's why I've moved towards that. How about you, Bill? Do you like needle app or collagenase?
So I don't have collagenase in my clinic, so that makes it a very simple decision for me.
Yeah.
Yeah, you have to have a refrigerator for it. I mean, I'm the only hand surgeon up in that office, so it doesn't have it. You have it in the Smyrna office?
Oh, I have no idea. That seems like a Kelsey problem, to be honest.
Yeah.
Like I offered everyone, so it's like if somebody actually took it, nobody's taking it from the Smyrna office, but like if they did, I guess Kelsey would tell me if the patient had to come to MSK. You can do anything, Paul. For the longest time, I didn't know you could build a needle app in the clinic. So if you do stuff for free, you can do anything.
Yeah, you just have to pre-serve. That's what you have to be careful about with the clinic, because you have to like
Yeah.
sign them up, fill out the thing like you're doing surgery, and then you bring them back to the clinic to actually have it done.
And who knows with our new coders,
Yeah,
what's going to happen.
first.
Do you guys do it at 7 days? Like, or like when would you come back for your collagenase? Because there's like people are different.
Do you mean after the injection?
Yeah, after the first injection. You know, like the manual says
Dude,
4 days, but I did seven
I
days
do
usually.
72 hours. I don't know. I don't know
For
if
three
that's right.
days.
Like 48,
At
72
the V,
hours.
I only had clinic once a week, so I brought him back 7 days later. But at Emory, I've got back-to-back days of clinics, so I have done 24 hours, and it seemed to work equally as well. And I don't remember having a higher rate of skin tears, but I probably didn't do that many to have like a good handle on it.
Yeah, because I usually because Tim, what would Maureen bring them in? Like when would she bring them in?
She would do one week typically.
Yeah. I have found like because then the edema goes down because I did it originally like very early in Canada because I did it right by the book like because I think the manual says 72 or something but um then I noticed like if I just waited a bit then the thing was less. So
We had some surgeons at the VA who would do it like 48 hours after, and they seemed to have similar outcomes. At least what they told me, they had similar outcomes regardless of whether they did it then or waited a full week.
And like you said in your talk, they do get pretty swollen and bruised up. Everyone's a little bit different, but a lot of people get swollen and bruised. If you bring them back at 24 to 48 hours, they will still be swollen and bruised and they'll kind of be a little upset at you. But if you wait a week, they don't, they're like, oh yeah, that got better. And so sometimes they're just a little bit happier.
Thanks for that, Dr. Sue and everybody. I was wondering if somebody presents like with overlapping pathology in like a diabetic hand, for example, does that alter your decision whether or not you want to be less invasive with the Dupuytren's, more invasive? Do you stage things? Do you kind of do everything all at once? Like what your thought process is with that?
what's your thought process on that? So if you had a patient with Dupuytren's because it is increases your odds for Dupuytren's. So what would you do if a patient with Dupuytren's came in with diabetes?
I meant if they also had like triggering digits, like maybe in other digits or carpal tunnel, like peripheral neuropathy, like if they had evidence of all of those things, would you be more or less apt at being more invasive with the Dupuytren's and like handling everything in the OR, or would you like stage those things?
I think me personally, I'd probably deal with the Dupuytren's like my normal algorithm. Like I deal with the condition normally. So if I felt like this was a very aggressive or severe contracture and I was thinking of surgery, I'd probably still do surgery. Maybe I would do surgery on other, like if it was like a carpal tunnel at the same time, I maybe just would do a carpal tunnel at the same time. I don't know what other surgeons think.
Gotcha.
Yeah, I mean, my
I
my
would agree with
sense is
that.
it, how about this a question for y'all? If you have a 90-degree contracture of the PIP joint, what are y'all doing? Dupuytren's associated with a 90-degree contracture of the PIP joint. You guys just going and doing a open fasciectomy and then trying to reset that PIP joint, or how are you guys treating that patient? This is for my colleagues, but I guess the fellows can chime in too.
Start with maybe a digit widget and then try to get a little bit of correction, and then consent them for a possible skin graft once you go in for a limited fasciectomy.
Limited fasciectomy. I probably wouldn't do a limit. I'd probably do a full fasciectomy if you have that bad of a contracture. But so what do you guys, Nina, agree, Nas, what are y'all doing for these patients? Because here's my approach, and maybe this is not the right one. I've done everything. I started out doing the whole thing and then I do check rein release. And I found that the Dupuytren didn't come back, but the PIP contracture came back right away. And no matter what I did, splint them for 2 weeks, night splint, all that stuff, they still eventually, the PIP contracture came back. So I was like, all right, screw this. Gottschalk was all into this digit widget. So then I started doing digit widgets on them. And I would do digit widgets beforehand. And we did digit widgets beforehand. We get them stretched out and then I go do the check rein, or then I go take it out, and in the second stage when stretch out. Well, actually, when you stretch out, you don't have to do a skin graft cam because it stretches out the skin, so you can do a fasciectomy or whatever. But we had all kinds of issues with like I had patients shutting these damn things in laundry machines and car doors and breaking them and fracturing metacarpals and all this all nonsense. And my team started hating, absolutely hating. Ask Caitlin and Sarah what they think about digit widgets. They fucking started hating those because everybody did everything imagined to like hurt themselves with the digit widget. So like, I mean, yeah, that kind of worked, but also I had like many complications, like not complications from the digit widget, but from people doing shit with the digit widget on. So I don't know. I'm not sure if I have like a great answer for these. Maybe the digit widget, but like I don't know. My team hates that so much. I feel like I like cringe every time I suggest that to them.
I would agree with you. I personally think it's like, first of all, I've actually had a hard time convincing patients to do the digit widget sometimes because I will show them what it looks like so they understand what it looks like. Like, can you handle this? And a lot of people haven't. I think the quote unquote correct answer is probably doing a digit widget, getting it straight. That way you don't have to do skin grafts, and then doing the fasciectomy afterwards is probably the correct answer. I think realistically, what I end up doing is I will do a limited fasciectomy and then also consent them for like an antecubital, like full thickness skin graft or something like that. And splint for 6 weeks, even though the literature wouldn't indicate that.
I still, sometimes I'm like, how old are they and what are they looking for? Because like if it's somebody who's old and they don't want surgery, I might still do a needle app just to get them to like 45 degrees or something, And then it's like, okay, it's better for them, but it's not perfect. And I tell them like, hey, look, it's probably not going to be perfect. If it's like guy in their 50s and they want it to be perfect, then yeah, I think surgery. I have not done any digit widgets so far. There's like one or two people I've thought about it in, but I've just, gone straight to surgery, release them. I've not pinned the joint in extension, but if you do like a full like PIP joint release, like yeah, I agree. Like splinting them is hard to like keep that out. So for like standard PIP contractures for like trauma or other reasons, I have pinned them for like 2 or 3 weeks sometimes. And so I'd think about that to try and keep them extended. But then they get stiff and stuck in extension, and it's hard to like rehab them up to flex again. So, it's kind of like trading off. So, but yeah, I haven't done a digit widget. I agree. They're kind of finicky. I remember doing a couple in fellowship.
One thing I will say, which I've moved away from, which Wags mentioned, was that, let's say you have a little bit of a residual contracture. It used to bother me a lot. So I would go in there and do a check rein release. I've stopped doing that though. I feel
Mhm.
like once you start getting into the check rein release, doing like a volar plate release and stuff like that, then you like make them unstable so they pop. And I think that makes it worse. So I've made them accidentally because you can't really, like, you can't titer that perfectly. So when I've actually done that, like then I've made them too unstable. So then I've had to flex them so they don't dislocate on me. And so I've actually moved away. Like, so I warn the patient if it's very bad at 90, I usually warn them straight at the shoot, like this will not be zero. It will not be neutral. It will be like if I can get to like 20, 30 degrees, like just like Paul said, like if I can get it to a better spot than you have, I think we should accept that because it's like the tension on your nerves, like the lack of instability. So I've moved away from doing the check ring release. I used to do that all the time because it used to bother me. Like I'm here, I'm going to make this straight type of situation. And I thought that was worse.
I think that's true. I think once you like either, sometimes they do like a closed manipulation of it and kind of tear that check grain, or like if you do an open release, I think it scars more after you do that, and it's just it can sometimes make it a lot worse. I agree completely.
Yeah, I just accept that they're not going to have a perfect neutral PIP joint. And I think that's probably the least of all the ills. I don't have a whole lot of experience with the digit widget, but I agree with most of the things people have said.
All right, team. Well, it's almost 9. Thank you so much.
Thank you.
Oh,
Sorry,
unless-
sorry, I had
job.
nothing to contribute, guys.
If we have a nerve injury,
Call me.
Yeah, if we have an injury, you're on it.
You know, I
You're
actually
on
did
it.
put two digit widgets on somebody, and one of them got infected, and I had to do a ray amputation. So that's my experience with the digit widget. It was not for
Great.
Dupuytrens
That
though.
one very poorly, actually.